Good evening, everyone. On behalf of East Melbourne PHN, I wish to welcome everyone to this Adult Asthma What's New webinar, sponsored by the National Asthma Council. My name's Stephanie Lenko and I'm a GP facilitator for East Melbourne PHN. Kathy Tepper's going to be helping me in the event that we get flooded with questions from you all or experience any IT challenges, and Josie's helping us with the video recording this evening. I would like to acknowledge and thank the traditional custodians on whose unceded lands we gathered this evening. I acknowledge that I'm working on the land of the Wurundjeri people of the Kulin Nation. I wish to pay my respects to elders past and present, and I acknowledge that Aboriginal and Torres Strait Islanders are the first peoples of Australia. I'd like to thank them for their care and protection of this beautiful country. So some housekeeping. To keep track of questions, your chat has been disabled, but we will welcome questions throughout the presentations, and you can ask the question either by clicking and putting your hand up, and then we'll let Kerry know that there's a question there that she can answer at that time, or you can type your question into the Q&A and we'll go through them as they come in. This webinar is being recorded and it will be made available on the East Melbourne PHN website in a few days' time. Also, an upfront reminder that we do really value your evaluations, which will pop up at the end of the session. I'd like to introduce our presenter from the National Asthma Council. Kerry Banks is here tonight with us. Kerry trained and worked as a nurse at Guy's Hospital in London. After immigrating to Australia 12 years ago, she then specialised in respiratory nursing and ran a severe asthma clinic at Frankston Hospital. More recently, Kerry has been working as a clinical trial asthma educator for a pharmaceutical company. Welcome and thanks, Kerry.
Thanks, Stephanie. Just checking you can hear me okay and look at the slides as well.
Yes, perfect.
Perfect, yes. Apologies for my spelling of my name. I actually am from Wales originally, so it's the Welsh spelling of Kerry, which does cause much confusion, as you've realised. So thank you everyone for joining this evening. There's actually about 60 slides to get through. So some of them I'll brush over a little bit quickly because in the interest of time. And as Stephanie said, just raise your hand. I think I'm happy to take interruptions actually because there are a lot of slides and I think you might get a little bit fed up with my voice. So I acknowledge the traditional owners of the country on which we work and live, and recognise their continuing connection to land, water and culture. I pay my respect to elders, past, present and emerging. So this evening, the topics we're going to cover are the Australian Asthma Handbook and the new changes that have recently come into play. We'll look at asthma pathophysiology and triggers, try saying that after a few drinks, how to diagnose and manage asthma in adults and adolescents. And then briefly at the end, if we're not all exhausted, we'll look at written asthma action plans and then asthma in a primary care setting and the COVID-19 guidelines. And based on the topics in the previous slide, these will be your learning objectives for the evening. So if you wanted to, take a photo of this slide, if you wanted to put it in for your CPD record, so your continuing professional development points. Much of the content of this presentation will be found in the Australian Asthma Handbook. It's a free online publication and it pretty much contains everything you're ever going to need. And I promise you it's very practical and useful, written in plain English and with pictures. And as well as the handbook, have a look at the National Asthma Council website as well. It's a really, really good resource for posters and patient information. And Sal, the lady on the desk there, is really good at distributing information as you need it. And also, if you go onto their website, they've got how-to videos, and it shows you how to specifically use certain types of inhalers. Now, this might sound quite obvious to some, but there's so many different inhalers out there now that we really need to make sure patients are using them correctly. I'm sure you've seen all the research out there that shows that basically 50% of patients use 50% of their medication. So pretty low compliance when it comes to medication in general, and certainly that carries across to asthma medication as well. So have a look at the videos they've got online. What I did when I was working at Frankston Hospital was I downloaded those videos, because you're allowed to do that, put them onto a USB stick, and I had them on replay in the waiting room. So not a very exciting place to sit for hours and hours, but certainly it got the message across, because you have to keep reinforcing it to patients. So the Australian Institute of Health and Welfare, a couple of years ago in 2020, concluded that over 2.7 million Australians have asthma. 1 in 9 of them have asthma. So that's pretty high by international standards. But there's many allergens and triggers in Australia. And of course, we've got much better diagnostic tools than other countries. Also, a bit morbid, but the death stats are, in 2020, 417 people died of asthma. Since 2001, there has been a general decline in children and young adults in the diagnosis of asthma. Pretty stable in those over 35, but generally a decline in children and young adults. So you're probably thinking, why would that be? But it's actually due to better diagnostic procedures. So what was previously just an umbrella term, asthma, people are now actually taking these patients down to the lung function lab and actually working out if it really is asthma. We're still finding it's much more common in boys than in girls, but then after adolescence, it switches. So we're still trying to work out why, but it does seem to be influenced by hormones. Fewer adult men are diagnosed with asthma than women. And this is actually because men are less likely to go and see their GP. They don't like to go to the GP unless they're really ambushed into it by their wife, it seems. But that is why we've got fewer men diagnosed with asthma. 50% of people with asthma are over the age of 75. And some have not been diagnosed properly by a doctor. And that's because they've put their breathlessness down to really old age and just general huff and puff rather than actually inflammatory disease. Now, the next bullet point is quite an alarming statistic. It says 30% of people with a diagnosis of asthma in primary care may not actually have it. So that's worth repeating. 1/3 of people who walk into your practice with a diagnosis of asthma may not actually have asthma. And as we go through the presentation, you'll see that although they may appear to have symptoms of asthma, they've got something else going on. All that wheezes is not asthma. So what exactly is it? It is a chronic lung disease which can be controlled and not cured. And it can stay controlled for many years. And then without warning, and for whatever reason, it can reoccur. It's important to remind patients that it cannot be cured, as so many believe, doctor, I'm cured, no symptoms at all, but they're not cured. They are merely controlled, and the symptoms might go away temporarily, but they can come back. In clinical practice, asthma is defined by the presence of both variation in lung function and variable symptoms. And these symptoms can be variable over time and in their level of intensity. So variable lung function, I'm sure you know, we can measure objectively with spirometry, or what I've got to hand here, a very old peak flow meter. So we can measure objectively what's going on in the lungs with one of these or spirometry. And of course, you can ask the patient, how are you feeling? What are your symptoms like? And they'll tell you what sort of wheeze they've got, shortness of breath, coughing, mucus production, etc. So it's objective measurement or subjective measurement. That's how we define asthma. So this is possibly the most important slide of the presentation. And I'm so glad it's at the beginning and not at the end, because it's really important to understand the physiological changes in the airways in asthma. Excuse me. On the left of this slide, you have a picture of a normal airway. Then on the far right, you've got an asthmatic airway during attack. And it's really important to stop the normal airway looking like the one on the right. So as you can see, the normal airway has got nice pink epithelial cells of muscle wall, and the airway is wide open. But as that asthma flare progresses, there's increased narrowing. The epithelial cells become really, really red and swollen. And then the smooth muscle on the outside starts to tighten, and it squeezes the airway closed even more, and you get mucus production. So there's 3 components you've got to consider to airway obstruction. And I've got my noodle here to demonstrate. That's why I wasn't blurred earlier. So you've got a nice visual of my bedroom as well. But these noodles are a great way of demonstrating to your patients what these 3 components are. So just to repeat, on the inside of the airway, you get inflammation. This is where the epithelial lining inside the airway starts to swell. It becomes irritated and inflamed. And then you often will get, you can't see this very well, a blob of mucus. In this case, it's just a lump of glue, further obstructing the airway. And then on the outside, you see it goes all bumpy. You get ridges all the way down here. This is where the muscles wrap around the outside of the airways and contract, and they squeeze and constrict. And it makes it harder and harder for a patient to get air in. This is beautiful, this one. You can see right through it. This one, they really can't get the air in and out. You probably can't hear it, but you hear a very faint whistle as the air is desperately trying to get in past that mucus blob. And the reason it's so important to appreciate the 3 different events of inflammation, mucus, and squeezing is because reliever inhalers, such as your Ventolin, work by relieving the muscles on the outside. That is what a Ventolin does. Ventolin eases the squeezing on the outside, and that's all Ventolin can do. Inside, you've got the inflammation and the blob of mucus. The only thing that's ever going to treat that is your steroid inhaler. So all those patients who are not using their steroid preventer inhaler are more likely to have symptoms of asthma. But of course, Ventolin works quite quickly, so you can release that squeezed muscle quite quickly and you get instant relief. Reducing the inflammation takes a lot longer. In fact, it can take about 2 weeks for a preventer inhaler to have full effect. So somebody who's not taking their preventer regularly is not ever going to really get on top of this inflammation process. But of course, they're going to love taking the little blue Ventolin because it stops the squeezing. But you must remind your patients they have to be taking their preventer therapy. So what are the characteristics of asthma? As I've said, you've got your inflammation, your tightness, and you've got your mucus. And these will all produce the recognizable symptoms: coughing, wheezing, shortness of breath, and chest tightness. But these occur in varying amounts. Unlike COPD, asthmatics have really quite variable symptoms. They'll have good times and bad times, but often these conditions will fluctuate. COPD patients are generally on a steady decline with their lung function. They just seem to be steadily getting worse, and every exacerbation will only make them worse. An asthmatic is quite different. They can exacerbate, but then they'll get right back up to where they were. Unless, of course, they've got overlap disease, where if they've got any traits or symptoms of COPD, they'll be on that general decline as well. But generally, asthmatics fluctuate. Now, the bullet point here in the middle, it says, asthma can be reversible, often reversible either spontaneously or with treatment. So what does that mean? You might have seen that on the bottom of a lung function report, but have you ever stopped to think, what does reversibility mean? If you see reversibility written on the bottom of a lung function report, it means that patient has had reversibility to Ventolin. It means their symptoms have reversed when you've given them Ventolin. And the amount of reversibility, the amount their symptoms improve, is an indicator of control, because a controlled asthmatic, one who's taking their preventive therapy regularly, is less likely to show reversibility because their asthma is more under control. It's the uncontrolled asthmatics who are more likely to have a response to Ventolin. So if you try and remember that, we'll come back to it later, but if you've got increased reversibility, a bigger improvement in your symptoms when you take Ventolin, your asthma is less controlled than it should be. And incidentally, there's no pain receptors in the lungs. Otherwise, asthma would be a very painful disease to have. So what are the triggers that can induce asthma symptoms? I mean, there's loads. We could fill the page with them, I'm sure. But it's really important to know what conditions can make someone's asthma worse. Everyone is different. I used to share an office with someone and she'd come in during the winter and go, oh, my asthma's terrible today. Cold was her trigger. It's not my trigger. But some people you'll find pollutants, smoke. Certainly during bushfire season, we'd see patients having flare-ups of asthma. Pets. This is one of mine. Cats. I don't like cats. I can't go into a room with a cat. That will set me off. You have to get used to recognizing what your triggers are. And also, more recently, we're seeing with asthmatics is stress and anxiety is triggering asthma symptoms. So again, look out for that one and try and treat the anxiety component rather than just keep treating the asthma, because the asthma will just keep flaring in response to the anxiety. So once you've identified what the triggers are, then you can implement management strategies. So for example, like I said with myself, because I know cats are my problem trigger, I will avoid going to the house of a friend who's got a cat. Again, if you know you've got certain additives, avoid those foods with those additives in them. Again, if stress is a big one for you, I mean, obviously you can't move your whole family out, but you know, if your mother-in-law causes you stress, just don't get the lady around so often. And also consider that certain medicines can trigger an attack. So you'll be familiar with aspirin, but certain cholinergic agents as well can also trigger asthma. So you've got avoidable and unavoidable triggers. Exercise, it's a big one, of course. We know that you get these exercise flare-up of asthmas. Laughter, certainly nobody should be denied a good belly laugh. So don't avoid those things. I don't really have any advice about those, but certainly be aware they can be a trigger for somebody. And of course, when you have worked out what the trigger is, make sure someone is prepared to deal with it. So if they get triggered by a respiratory tract infection, make sure they've got a script to hand of antibiotics and manage their comorbid conditions as best you can. So hormonal changes, pregnancy, the physiological, psychological changes, just be aware that things could get worse at certain points of someone's life, menopause, etc., or when someone reaches adolescence. So avoidable triggers, cigarette smoke goes without saying, really. Cockroaches, dust mites. This was one for me as well. It took me a few years to realize, you know, when you're younger, you go to parties and you just end up crashing on someone's floor. And I always used to wake up with asthma symptoms. I thought it was alcohol induced. I then realized, no, it was because students don't vacuum their carpets. I was actually allergic to dust mites. I realized it. I stopped crashing on floors. It's an easy thing to recognize, you'd think, but actually it took me several years to realize that. Also, asthmatics should try and minimize exposure to certain irritants, so perfume, spray. So maybe don't walk through the Maya section of the makeup and perfumes that upsets you. Thunderstorms, of course, follow the advice given through social media about thunderstorm asthma. And also, like I said, dietary triggers. Some people, unfortunately, get triggered by having cold drinks or ice cream, so they're going to suffer if it's a really hot day. But just be aware of those triggers and try and manage them as best you can. So adolescents, where do they fit? So various age ranges are used to define adolescents. In the Asthma Handbook, they state it's approximately age 12 to 18 years old. And it says that those under 14 should definitely be managed as children, and those maybe over 14 could be considered as adults. But of course, there's much fluctuation there because some people may not mature until, early 20s. Either way, it's a time for them of rapid growth, not just physically, and this has to be taken into account, cognitively, emotionally, and socially. And it's also when you've got those mental health issues coming into play. It's also a time when more risky behaviours start. I remember those days well, great fun. But also it's when they start to experiment more. So you've got the poor diet, physical inactivity, possible drug and alcohol use. Smoking rates generally now are on the decline, but of course, as you'll be aware, you've got the vaping to consider as well. Also, the other bongs and hookers and all the other things that they take. Certainly the days of Audrey Hepburn are over. But take all these into account because asthma can worsen or improve during adolescence. And children's knowledge of asthma can improve during this time as well, as they learn about their triggers and avoidance strategies. But they rebel. They always rebel because they don't want to have a chronic disease. They want to be the same as their friends, as their peers. And of course, research has shown that adolescents with a chronic disease have a higher risk of concerns because they have higher risk behaviours associated with their disease. It's like they've got something to prove. I mean, I'm not quite sure of the background for the people who are watching this webinar, but I had a background once in renal medicine, and you'd always get those young people coming in. They would drink many, many pints of lager, then they'd come in for dialysis. And you just think, why would they do that? But this goes back to the research. They have high risk behaviours if you've got a chronic disease. So less than 1 in 5 of adolescents in Australia will have an asthma action plan. And only about a third will have discussed their asthma with their GP, which is quite sad. And now I do have a good example here. And I often find examples are the best way of getting the message across, but I was volunteering just a few months ago. I don't know if you're aware of those timed 5-kilometre runs, which they have worldwide, but certainly they have them in Australia called Park Run. I was volunteering and there was a young girl there running, and she was running holding a very conveniently sized Ventolin inhaler. So she ran her 5 kilometres, and afterwards I caught up with her and her mother, and I just said, why are you running holding your Ventolin? And the girl and her mother said, yes, my asthma's not been so good. I have to run with it in case, obviously, I have symptoms when I'm going around. And if you remember from that slide, of course, if you're taking your preventer inhaler, you'd be addressing the inflammatory process that's going on in the lungs. So the mother was very keen to take the girl back to the GP. And I said, look, before you do, just watch her use her preventer medication as prescribed for 2 weeks. So that's 2 puffs twice a day for 2 weeks. Just do that as an experiment. If your asthma symptoms are still not under control, then please go back to the GP. You can probably guess the rest of the story, can't you? In 2 weeks' time, when I saw them again, she was not running with her Ventolin inhaler because she was then taking her preventer medication as she should have been doing. So do delve a little bit deeper when your patients come in. Absolutely make sure they are taking that preventer medication as prescribed. And with children, do not assume just because the parent was very good at managing that child's asthma, don't assume that that child is therefore very good at managing their own asthma. It doesn't work like that. So how else can we help the transition from parent management to adult management? Basically, support, education, and planning, and lots of reinforcement. Financial bribes if you have to, but it's basically a 3-phase process because you're working towards an adolescent being able to manage their own care and accept that this is a chronic disease that cannot be ignored. You may have heard of the AAA program, and the AAA stands for Adolescent Asthma Action. And this is really a series of education programs designed specifically for adolescents to improve asthma-related quality of life. And it takes into account the emotional, the psychological, and social implications of having a chronic disease. They improve asthma knowledge by encouraging them to use a spacer correctly, maybe finding a spacer that's smaller for them to take to school. And in this way, they can hopefully reduce symptoms and the amount of absences that someone has from school. So, diagnosis of asthma. There's no gold standard for the diagnosis of asthma. It's really based in three parts. First of all, you've got to look at the history of that person. So that will include your family history, the tendency to develop allergies. You then do a physical examination. And then, of course, you would need to do a diagnostic spirometry test as well, possibly allergy testing as well, or provocation testing. You could also do blood tests. It's worth looking at someone's inflammatory markers in their blood. So again, if you've got an asthmatic in your clinic, if you've got a set of blood results there, have a look. If they've got a high IgE or high eosinophils, both of those markers are suggestive of asthmas. Because biomarkers is something in your body that indicates something about your health. So whereas you'd look at the white blood cell count for a patient, which might indicate, oh, high white blood cell count, they must have an infection, high IgE and high eosinophils can indicate allergy and asthma. And if you're interested at all, you could also do a spirometry course through the National Asthma Council. They do that free of charge as well. So as well as the history, the physical examination, and the diagnostic testing, you could actually give them a bronchodilator. So you could actually send the patient away with a Ventolin or advise them to buy one over the counter and see if it makes a difference to their symptoms. That in itself is not a diagnosis, of course, but it's a good indicator. If their symptoms improve with Ventolin, they could possibly have asthma. It's a good indication. So history, what symptoms does a patient have? Is there a family history of asthma or atopy? Is there a personal history of atopy or allergic disease, possibly in childhood, and as they've got older, these symptoms are rearing their head again? Have they had hay fever in the past or allergic rhinitis? Ask about triggers again. We always come back to triggers. Is there anything that specifically sets them off? What's the patient's smoking history? Have they smoked in their childhood? Have they given up? Have they started again? A smoker might be showing asthma symptoms, but of course you'd really need to do spirometry to work out if it's asthma or COPD or a mixture of both. So after history taking, consider your physical examination. Look at how the patient is breathing. Watch their respiratory rate. It can actually be surprisingly fast. Everything else might appear normal, but you might see that that respiratory rate is creeping up. And chat to the patient. Is their nose blocked? Are they mouth breathing, for example? Look at their chest. You know, sometimes you get this barrel chest, and that's because people get trapped air and they get hyperinflated lungs. And that's really where the asthma's been left untreated for years. And of course, it could be COPD. You get barrel chest with COPD, but have a look at the shape of somebody. When you're talking, can they finish a sentence completely? Can you hear a wheeze? And with children, this is quite a cute one. There's a so-called allergic salute where they haven't really demonstrated it on a slide, where the patient will just rub their nose up all the time. And you'll find that some children get a really small crease just across the top of their nose. And it's because they've got this constant dripping of rhinitis. So look at a little groove across the top of the nose, another good indicator. So your third and final step really is spirometry. So they say there's no gold standard, but this probably is about as close as you're going to get. So spirometry measures how easily, how quickly, and how much air passes through the lungs. And you would perform spirometry before and after Ventolin. For the reasons I've said before, you want to see if the symptoms reverse in response to Ventolin. So a lot of people will use a peak flow meter, but these are really only good for home monitoring or really putting together an asthma plan so you know what your baseline reading would be, because a peak flow will only show that individual's variability. It won't take into account their age, their gender, or their height, or their ethnicity, because all these things can influence their lung volumes. So it's useful without doubt, a peak flow, but it's not a diagnostic test on its own. You really need to have spirometry for that. So after all of those three things, the history taken, the physical examination, and the spirometry, what else would you do? You might want to look at skin prick testing, and as I said, blood testing. You could do something called provocation testing, or it's called a trigger test. So if you think someone's allergic to something, I mean, the example I've got in front of me here is, if you think a baker is allergic to yeast, expose the baker to the yeast under controlled conditions and observe if their lung function changes. Obviously, it has to be controlled conditions because you don't want them to have an asthma attack, or certainly not be supervised, but that would be a provocation test. And certainly if you go to lung function labs, they can do that type of testing. You could do a chest X-ray. It's not routinely required, and it certainly will not show you asthma, but it will rule out other things. And it will also show you if someone's got hyperinflated lungs, which of course, as I said, could be because they've got long-standing untreated asthma, and they've got this remodeling of the lungs and scarring as a result of that. And future tests, I think we touched on it, was eosinophilia. Check your eosinophil levels in your IgE. And a more recent one, I don't know if you would have a nitric oxide meter in your practice, but it's a very small breathing apparatus which you can just pop on a desk. A patient can blow into it. If they've got high levels of nitric oxide when they expire, also indicative of asthma. It's a very simple test. Sadly, it's quite an expensive machine, but very, very useful. So asthma is more likely if your symptoms are recurrent or seasonal, if they're worse at night or early morning, if they're triggered by exercise or irritants, allergies, viral infections. Also, if the symptoms are rapidly relieved by Ventolin. The word rapid is really important here. You're really looking at 4 to 5 minutes. That's how quick Ventolin works, probably even quicker, maybe 2 to 3 minutes. If a patient says to you, oh, nurse, doctor, I took the Ventolin and I sat down for about 30 minutes and then I felt better, it probably hasn't been the Ventolin. Ventolin acts fast. That's why it's used in emergencies for asthma, very fast. It's also more likely to be asthma if symptoms began in childhood. Also, if you've got someone's lung function tests back and they're much lower than predicted and you've got no other explanation for it, then sadly that would also suggest it's asthma. And as we said before, do look at the IgE and the eosinophils. They are a great indicator and they're probably already sitting in the patient's source notes in your practice. So have a look at that. And certainly high eosinophils, anything over 0.3, 300 would be indicative of allergy. So you've gone through all that and you've determined it's not asthma, because all that wheezes is not always asthma. So what is it? Because if you've got 30% of patients in primary practice diagnosed incorrectly, what's going on? So if someone comes in with a cough, don't assume it's asthma. It could actually be one of those non-specific coughs that certainly people can get. It could be acute viral bronchiolitis. And of course, many young children, mine included, had a viral-induced wheeze due to bronchitis or respiratory infection. And that's why you've got the number of children diagnosed with asthma now going down, because people are recognizing that it probably isn't asthma and they're treating one of those other conditions instead. Also, not so common, but consider it could be a structural problem in a child. So tracheomalacia, where the trachea narrows or collapses during breathing. And other respiratory conditions you might want to consider are, as we said, the uncontrolled rhinitis, because if you've got a dripping nose, that's going to cause a patient to cough. So remember that nose rub and the asthma salute. Also think about bronchiectasis, that could be involved there, and of course, COPD. So if you've got your asthma diagnosed and you're sure it's asthma, how are you going to treat it? Because this is a chronic disease. It needs ongoing care. It's not going to go away. You're going to have to constantly adjust and assess and review with the patient. It changes over time. You can't just treat that initial attack. You've got to have ongoing self-management education with that patient, because they've got to take responsibility for themselves, and they'll require an asthma action plan as well. So an awkward conversation to have, but someone's got to have it. Encourage that patient to lose weight and give up smoking. Being physically fit can certainly help. The fitter you are, the higher your threshold before exercise-induced bronchoconstriction kicks in. Obese patients are much more likely to report symptoms of asthma. Healthy eating, healthy diet, healthy lungs. None of this is rocket science. I've got another great example. I had a delightful patient from Scotland, actually. I've got a terrible Scottish accent. And his asthma was out of control. And he was very compliant with his medication. In fact, he actually went down, had surgery done. And you probably may not have come across bronchothermoplasty, but it's actually where you can go in and you can actually burn some of the lungs to reduce the inflammation. He had that done. He also then went on to these very expensive injections, monoclonal antibodies for asthma, but he still wasn't right. And then he got really quite unwell, and we thought, this is it for poor old Jim. He's not going to make it. But, you know, he pulled through, but he actually lost 20 kilograms in the process, and he gave up alcohol. Well, I'm telling you, this was a changed man. He was only 70, and sometimes he would look like he was in his 90s. And he bounced into our clinic one day looking absolutely fantastic. And we're like, Jim, what happened to you, mate? And he went, I gave up the grog. I gave up the grog. Basically, he was trying to say, look, I gave up drinking my 2 bottles of wine every night. And he also stopped eating the fatty meals. 20 kilograms, that was his problem. It wasn't even the asthma, it was the obesity. So have that difficult conversation. Even a 5% reduction in weight can really help a patient's breathing. So this is where it gets a little bit complicated. So if you want, Stephanie, I will stop at the end of this one. Don't be put off by it. It's a very, very busy slide, but I'm going to simplify it, okay? Because this is, if you go into the Asthma Handbook, this shows you how asthma should be managed. So let's start at the very, very bottom, where it says, few patients, reliever use only. This is applicable to a really, really small number of patients. Only those who use maybe a reliever very, very infrequently, and they don't have any other risk factors for flare-ups. So not many are going to fall into that level 1. The step up from this is level 2. This is where most asthmatics sit. This is where I sit. And this is where the guidance has changed. So it used to recommend initial prescription of a low dose inhaled corticosteroid as a daily preventer. So something like maybe a Seretide, something like this, take 1 or 2 puffs twice a day. Off you go, thanks very much. But as I said earlier, patients don't do as they're told. 50% of patients will use 50% of their medication, probably 50% of the time. It's pretty poor. So what do? You cannot change people. It's really difficult. So you have to work with them. So what one of the companies did, they came up with a really ingenious plan. They said, let's make something that looks like this, but works better. So they came up with this. It's red. As far as the patient's concerned, not much different really. One's blue, one's red. And the company said, look, just use this instead of your Ventolin. If you can't be compliant with your preventer, just use this as needed. Genius. And it works because this red inhaler, a budesonide formoterol, actually has low dose steroid in it. So of course, when the patient has symptoms, we know this doesn't work on the inflammation. We had that discussion at the beginning. It's never going to work on this. But if the patient takes this one instead, it's going to address both. It's going to address this inflammation here, and it's going to address the squeezing on the outside. Now, you're probably thinking, but does it work as quickly as the Ventolin? Because this works in 2 or 3 minutes. And this is a long-acting beta agonist. It's a long-acting beta agonist. It doesn't mean it works slowly. It works quickly. It lasts a long time. It can last up to 12 hours. So it's a win-win for patients. It will last longer. It provides instant relief, and boom, it actually attacks the inflammation as well. So it's a no-brainer. If you've got a patient who is not compliant with their preventer medication, think about changing them to PRN, budesonide formoterol, which is actually, the brand name for this would be Symbicort. And you can actually take 24 puffs of this if you wanted to every day. If this wasn't your bag, you could always take one of these instead, the Turbohaler, but you can only use 12 puffs of this because it's got a higher strength inhaled corticosteroid in it. So really a very good piece of research there, and I do commend the company that came out with that idea. Really, really good idea. So all those patients you see who are walking into your office all the time, and they might be holding a Ventolin in one hand and they've got their mobile phone in the other because, you know, they've got 2 hands so they can hold the essential things in life. Break the habit, switch them maybe onto this one, and they'll become less reliant on it. As time goes on, the asthma will be much better under control. And this is a huge change in asthma management, huge, as you can imagine. As you move up this ladder, the other steps have not changed. It was really only step 2 that's changed. So as you go up, you introduce higher dose inhaled corticosteroids as preventers. You can also add things on. You can have maybe oral prednisolone, which is not ideal, but for some people that might work, having maintenance prednisolone. And of course, as you go higher and higher up, you'd look at referral to a specialist because there are monoclonal antibody treatments out there which might be suitable for that patient. But one word of caution, before a patient is stepped up on this pyramid, check compliance. Make sure they're using their medications as they should. And of course, you can step them down if they need to. You know, if everything's going well for them, then they can step up and down. Also ask a patient why they're not compliant. Obviously, you're going to get the answer of, I forget nurse, I forget doctor, sorry. Understandable. Some of them might say it's because they get a hoarse voice. Some of these preventer medications are known to cause dysphonia. The patient has to gargle afterwards, not swallow the water, because you don't really want to swallow in that precipitation. You actually want to make sure it's gargled and it's out. You don't want it to go systemic. If it's not in the lungs, get it out. So gargle and spit, not swallow. I always say, Kate Winslet, back of the Titanic, good old gargle, spit it out. And that way you should minimize some of that precipitation on the back of the throat. And of course, the other thing is, if you've got one of those MDI inhalers, pop it into a spacer because you get much better deposition into the lungs with a spacer. This is just a close-up version of levels 1 and 2, which I just talked about, which is talking about either you can treat them with a regular daily preventer, or you can use PRN Symbicort to control asthma. And as I said, most patients you see will be sitting at level 2. So Symbicort PRN is a great starting place for treatment for most asthmatics. And patients like it. They don't feel tied to their medication. And before, Ventolin was like a safety blanket to them. So yeah, it's a revelation. And I'm probably going to stop there actually, Stephanie, because that's been the biggest change, like I said, in asthma management. So are there any questions? Throw them at me, whatever it might be.
There's no questions in the Q&A at this point in time. Is there anyone that wants to put their hand up and has a question? So if you go down to the toolbar, there's a raise hand symbol, and you can click on that. And we have got someone asking a question. You can now unmute yourself and speak. DPV Broadmeadows.
Yeah. Hi, thank you very much for the presentation. My name is Dr. Farhan. I'm a GP working in DPV Health in Broadmeadows.
Hi.
Yeah.
Nice to meet you.
Same here. Thank you very much. So my question to you, at what age we can diagnose asthma? So because I've got, as you mentioned, a lot of little children coming with wheezy bronchitis. So often they ask me this question, doctor, is this asthma? So what age we can confidently diagnose them to have asthma?
I was certainly 6, because you can certainly prescribe Symbicort from the age of 6. So that's probably the benchmark I've got, though I'd imagine some people would possibly diagnose it before that age. But most of the medications for asthma are from the age of 6 onwards, when they accept that a diagnosis has been made. I mean, what's your experience? Do you generally diagnose earlier than that?
Not really. Yeah. So whatever I've told them in the, this child is normally, if they're less, especially if they're less than 5 years old, I told this is not the age I can confidently diagnose this patient to be asthmatic. So normally, most likely, it could be a viral-induced wheeze. So normally, I give them PRN salbutamol for a few days or some oral prednisolone, and then review the patient. But of course, if the patient is older than 6, having recurrent symptoms, then we can think about diagnosing an asthma. But normally, over 5 years of age, that's what my understanding is.
Yeah, that probably ties in with the research then. I think the reason they've set most of these medications to be prescribed for 6 and over is because they've determined that to be the level of intelligence in order to perform lung function on a child. So they fully understand how to perform lung function. I'm sure there are patients out there who are younger, but they just can't diagnose it before then because of their understanding of how to perform spirometry.
Yeah, that's good. Thank you.
So you're probably doing the right thing. Yeah, probably doing salbutamol, just a treatment test to see if that works, and then move on to something else when they get older.
Okay, perfect. Thank you very much.
Yeah, the other thing might be is the nitric oxide, though, is quite easy for one of the younger kids to do, because they actually have made them child friendly, where they actually have a girl in a balloon or a candle for the child to blow out on a birthday cake. So that's one of the easiest things to do. So if you ever see a nitric oxide machine, you can get the child to blow into that. And if they blow higher than 25 parts per billion, that's an indication of asthma. So you wouldn't need to do the lung function testing, but nitric oxide testing is not commonly used yet, but that might change when diagnosis is made for children.
Okay, great. Thank you.
Okay, there's another question in the Q&A. Should spacers be used by everyone or just children?
Everyone should use a spacer. I use a spacer. Yes. If you've got an MDI, then definitely use a spacer, because I don't know if it's this presentation, but certainly one of them, it's got a graphical image of how much powder gets into the lungs with a spacer and without a spacer, and it's quite significant. You get much, if you don't use a spacer, a lot of it is going into your mouth rather than into your lungs. So yes, it completely enhances deposition in the lungs, and you really should shake the Ventolin every time, or whatever one you're going to use. You can use Serotype. Shake it every time, because with these MDIs, you've got to mix up the propellant with the medication, and it settles within about 15 seconds. So get into the habit of shaking and then putting it in and puffing. Other way around, that way around.
Okay, that's it for the time for the moment, Kerry.
Perfect. I told you it was long, didn't I? Okay, so you've already covered most of the content of this slide. Basically, a diagnosis of asthma means the individual should be on inhaled corticosteroid. You'd be quite surprised, actually, how many people would come into our lung function clinic already with a diagnosis of asthma, and they weren't actually on inhaled corticosteroid. So we don't care if it's mild asthma or COPD, asthma overlap. If there's an asthma component to their diagnosis, they have to be on inhaled corticosteroid. COPD, no, it doesn't necessarily work for a COPD patient, but if you've got asthma, you have to be on a steroid inhaler without exception. So as you know, a great way of getting a message across requires good social media campaigns. And the National Asthma Council is right behind the International Primary Care Respiratory Group, because they're on a mission to prevent overuse of reliever therapy such as Ventolin and the underuse of correct preventer therapy. So you may have seen this logo popping up on the right, hashtag asthma right care, but it's all about preventing people from overusing their Ventolin. So this slide basically wants the message to be that it is the mild asthmatics who probably don't really consider themselves to have proper asthma, who are at greater risk of having an attack, and who are probably at greater risk of thunderstorm asthma because they're not taking an inhaled corticosteroid. So people with mild asthma are less likely to be compliant, of course, with any preventer therapy given to them, because they'll go, oh, no, I haven't really got asthma, you know, it only comes and goes. But they're the ones you have to worry about and watch the most. They'll forget to take it on a holiday, forget to take it on their weekend away. And then, of course, they're going to have more symptoms. But don't go away from this presentation believing that Ventolin is bad for you. It really is not. Ventolin's fine. It really causes minimal side effects. Ventolin use is an indicator of control. Just remember that. It's an indicator of control. I hardly use Ventolin. I'm a severe asthmatic. I probably use it twice a year at the most because my asthma is under control. Go back to reversibility again at the start of the presentation. If I did lung function testing now, if you tested me before and after Ventolin, my lung function will be the same because my asthma is under control. Somebody else, on the other hand, that person who you might see walking down the road or doing a park run holding a Ventolin, do lung function on them. They're more likely to have reversibility because their asthma is not in control. They're more likely to have flare-ups. They're more dependent on their Ventolin. Take a moment to read the last line on this. If you use more than 12 Ventolin canisters per year, you're at increased risk of death than someone who uses 1 or 2. So that's a really strange sentence, which I feel is worth pointing out. Ventolin is not doing the harm. Ventolin is not going to hurt you. It just means if a person is using 12 or more canisters a year, they've got significant symptoms of asthma. They need to use that little blue puffer too much. Their asthma is not under control. By using a preventer, for example, they are less likely to experience symptoms and are at less risk of death. We have to get patients to change their mindset. They have to use a preventer and not be so dependent on their Ventolin. So if one of your patients is using lots of Ventolin, check adherence and check compliance. What's going on with them? Delve a little bit deeper, I should say. I would say peel that onion, find out why they're not taking it. Is there a reason? Is there a monetary reason they're not taking it? Because they are expensive, the preventer medications. But of course, long term, their health is important. So find out why they're not taking their Ventolin. Do they understand the benefits of the Ventolin? Maybe get one of these tubes out and explain to them the difference between what the preventer does with the information and what the the Ventolin does on the outside.
I have a question for you, Kerry.
Yes, sure, far away.
How should asthmatics be routinely assessed without sending them off for a test or having a lung function test?
We probably come back to that actually. You basically would be looking at the flare-ups of their asthma. So it'd be quite easy to see if their asthma is under control because of the number of presentations they're going to have. And if you're looking at their number of scripts they're getting, if they're not getting sufficient scripts of their preventer from their doctor, they're probably buying Ventolin over the counter. So that would be another red flag. And yeah, it's having that deeper dive with a patient. And sometimes you just need time to really talk to them. And we'd find that they would come in, they'd chat to the doctor, everything's hunky-dory. And then you find out, oh no, I ran out of my Brio about a month ago, I haven't been taking it. So it's probably having conversations, looking at their script usage as well. Just having that relationship with them.
Great.
We do touch a little bit more actually on control as well, because there's specific questions you can ask a patient to determine if their asthma is under control or not. So I know they appear later in the slide.
Okay. There's another question. Would you like that now as well?
Yeah, far away.
What is your recommendation for exercise-induced asthma? Do you consider a preventer for such patients if they exercise regularly?
That's a great question. I love that question, because actually, even though these slides talk about exercise-induced asthma, it has been classified now as exercise-induced bronchospasm. So they're recognizing that people who have exercise-induced bronchospasm are not necessarily asthmatics. So you would treat with Ventolin. Unless there's any other risk factors in there, like your allergies, or they've had prednisolone or exacerbations in the past, then yeah, exercise-induced asthma, perfect. Take a Ventolin. It's great for that. And yeah, think exercise-induced bronchospasm. A lot of sports people will say they exercise hard and they feel like burning in their lungs sometimes, and they get short of breath. These are kind of normal symptoms of bronchospasm because they've got these twitchy airways in response to exercise alone. Any more? I presume that was the last one, Stephanie, but I'll come back to time for questions. Yeah,
that's it for now.
As I said, they're on a mission at the moment to try and get the message across: stop Ventolin, take more preventer. And this is just a graphical representation which shows that more Ventolin equates to higher death rates, less steroid preventer use also equates to higher death rate. So inhaled corticosteroids, as I said, are the mainstay of asthma management in adults. And the handbook uses terminology of low, medium, high. What do they all mean? You don't need to remember this table, that would be ridiculous, but just be aware of its existence. If you go to the handbook, you can then check to see if a patient is taking a low, medium, or high preventive therapy. It's important to know what they're taking. And also bear in mind that doubling the dose of preventive therapy will not double the efficacy, because research has shown that you definitely get more bang for your buck, as they say, with the lower doses. So it's fine to take one puff, just make sure you take it at the right interval. So don't just take 2 puffs and then wait 24 hours for the next one. Take 1 puff and then 12 hours later, take another puff. It does minimize side effects, but it's a constant balancing act to minimize side effects, but keep your asthma under control. And it's tricky. It takes time, and you really want the patient to work with you to help you understand how it can be best managed. And again, I always go back to other things you can treat as well, not just the asthma. So think about things like, if they've got gastric reflux, treat that as well. If they're not sleeping well, maybe a sleeping tablet. Anxiety, give them anti-anxiety medication. So treat what you can treat as well, and then try and manage the patient with the asthma. Also, it's worth remembering, you shouldn't really be constantly treating a patient with prednisolone. Prednisolone is really for a flare-up. Maintenance prednisolone is not great because of the side effects to it. If you've got patients who are coming into you and using more than 2 courses of prednisolone in a 12-month period, they need to be stepped up that pyramid. And if they are compliant with their medication, get them to a specialist, because there's medications out there that can help them. So this is great. I use this all the time. You can't see it, but I've got one here on my wall now. I mean, the different devices are covered in another asthma presentation, but this is a great overview of the types of puffers that your patients are likely to be using. As I said, a diagnosed asthmatic will always be on inhaled corticosteroid and ICS, either in combination or on its own. It doesn't matter. As long as they're taking an ICS, then we're happy. Like I said, COPD patients, no, we don't need to worry about that so much. They could take a LAMA, a long-acting muscarinic agent, or they could take a LABA, or a combination of the two. Asthma must be on an ICS. And also remember, the script that is written is not just for the medication, it's also for the device. You've got 3 different types of inhalers out there. So you're familiar with the MDI, that's easy. Just squeeze, breathe in. You've got your breath activated inhaler. This is normally a dry powder. You just click it and then you breathe it in. But you've got to have a fair bit of inspiratory effort to breathe this one in. And this, if you've got arthritis, your fingers are going to slip on this. You can't do it properly. And you've got to breathe in the same time you press it. It's pretty difficult. So this might be easier if you've seen a Haler aid. You get them from pharmacies. Much easier if your patient's got arthritis. Just squeeze instead of having to slip your finger on the top. Think about a Haler aid. So there are 2 types of inhalers. The 3rd type of inhaler you've got, can't even open it, it's so difficult. That's the downside of it. You've got one of these. It's a dry mist. Beautiful. I absolutely love it. But oh my God, it's so difficult to load, to twist, to put the new cartridges in. So when you're writing a script out, can the patient use that device? Do consider it. So if you want to get hold of one of these charts, just Google it, it'll come up. Otherwise, go to the National Asthma Council, they'll send them out to you for nothing. They're absolutely great. So this is the question that came up. How do you manage asthma in adults and adolescents? You've got your diagnosis, we've agreed that. You've got to manage those comorbid conditions that affect the asthma, the stress, the depression, the allergies they've got, and then regularly review the medications with the patient. Step them up or step them down. We have to have control. That's really, really important. And provide written information to that patient, because most patients, within an hour of walking out of surgery, will have forgotten what you've told them. So you have to have it written down. Train them how to use their inhalers. Like I said, go and have a look at those videos online, because that's constant reinforcement. And believe me, they need it. Because if they've got poor drug delivery into their lungs, poor asthma control. It's not rocket science. So make sure the patient can use that device correctly and it's going into their lungs. And of course, offer them all the normal advice about avoiding the triggers, tobacco smoke, healthy eating, you know where this one goes. So asthma control involves 2 things: symptom control, and then looking into the future. Is anything going to change? Is that person going to get pregnant? Are they going to start IVF? We're going into summer. Are they going to be affected by certain allergens? So if need be, they might need to have more frequent follow-ups with the nurse or the doctor to make sure it's all under control. So how do you assess asthma control? Again, that was a great question when you said that. How do you assess it? This is brilliant. So when the patient comes in, don't just say to them, how are you going? You need to actually say, do you have symptoms more than 2 days a week? Are you using your Ventolin on more than 2 days a week? 2 days a week, not twice a day, 2 days a week. Do you have any limitation in activities? I.e., do you avoid using the stairs? Does your asthma wake you at night? If they answer yes to any of these, then asthma is not under control. And you're probably looking at that thinking, wow, using their ventilator more than twice a week. We've got loads of patients who fit that criteria. It's alarming, isn't it? They're all walking out this on the streets now. Their asthma is not under control. Patients need to be re-educated. Medication needs to be adjusted. Remember this line. The goal with a patient with asthma, they should be living life as if they do not have asthma. That is the goal. It's not acceptable to say, oh yeah, I'm all right. Yeah, I still wheeze a bit, still wake up early. First thing I do in the morning is I grab my puffer. That is not living life as if you do not have asthma. Therefore, your asthma is not under control. So get into the habit of asking your patient all those questions. And certainly, how often are you using your Ventolin? I had a patient once using one Ventolin in a day, 200 puffs, quite alarming. He thought he was fine. Thankfully, his wife realized he wasn't fine and dragged him into our clinic. And as I said, prednisolone, it should be used infrequently for the treatment of an exacerbation. If it's being used as a maintenance dose, then it's not ideal. Step these patients up, get them to a specialist because they could actually get an injection for their asthma. There's injections out there now where you can give them every month or every second month, and they work to reduce the eosinophil levels or reduce the IgE levels. And of course, if the eosinophils and the IgE are driving that inflammatory process, then these injections are really bringing their asthma back under control. So don't just think prednisolone is the only way out. Refer them up to a specialist. There is better treatment out there. So as I said, most of the reasons for poor asthma control is because patients do not understand the benefits of their preventer. They're not able to use their aspirin as prescribed, and possibly they've got interaction with other medications. So check what their other medications are. So with regard to patient perception and self-management, always try and understand what the patient knows. Do they understand what that preventer does for them? They have to understand, and then they're more likely to work with you. It's got to come from the patient. Every time you see them, review and reinforce. You need to do it because as soon as they walk out, they forget within 30 seconds, well, 30 to 60 minutes, I think I've been told, about 50% of what you said to them will be forgotten. So write it down, have a management plan. 78% of Australian asthmatic patients think they're well controlled. But I've told you what the conditions are for control. 13% actually are. So that's a massive difference. Nearly 80% think they're controlled, but 13% are. 58% of asthma patients are using their reliever at least twice a day. Definitely not controlled. So go back to that checklist. You'll find it in the Asthma Handbook and ask the patient, show me how you use your medication. Do they hold their breath after they've used their inhaler? It should be for about 5 seconds. Breathe in and hold it. Count to 5. Do it on your fingers. The time it takes you to raise your finger up to 5 is about 5 seconds. Try and get them to hold it into their lungs as long as they can. We need to get that medication into the lungs. And this is the other part of the question. How often do you review the asthma patient? Regularly, about every 3 to 6 months, because it takes 2 weeks for an inhaler to really make a difference. And if the patient happens to go into hospital, get them into surgery 2 or 3 days after that hospital admission. And then again, follow up every 4 weeks.
I've got a question. I've got a question.
Good, lovely. We're getting to the end. You'll be pleased to know.
What's the recommendation dose and duration of oral steroids for asthma exacerbation, both in children and adults, please?
I believe, I mean, I might be wrong. I might need one of the doctors to correct me on this, but you don't need to taper anymore. That's a big thing. Certainly, we're still seeing that in general practice, but the general guidance is hit hard. And shorter periods of time. If you're using prednisolone for less than 2 weeks, then you don't need to taper. Certainly in our practice, the doctors will prescribe usually between 25 and 50 milligrams for 5 or 10 days. So that's probably the only advice I can say. I can't prescribe, obviously, but certainly you don't need to taper if it's been used for less than 2 weeks. You still see that, but there's no reason to do that anymore.
Thank you.
So I will start to skim through these quite quickly because we're getting close to the time. Asthma management plan. This is really, really important. A patient needs to really understand how to put an asthma plan together, an asthma management plan, and an asthma first aid plan. An emergency first aid plan is when it's a true emergency, when they need to take action there and then. When do they need to call an ambulance? If in doubt, of course, call an ambulance. Asthma management plans, they're long-term. They take into account your comorbidities, your lifestyle, and your medication. Management long-term. Asthma action plan is when you've got this start of a flare. So there's 3 different types of plans you've got to consider. Your emergency one, which is quite critical, of course, your action plan for when you're worsening, and your management plan, which you will have running over several months. So an individual asthma plan should really develop so the individual can recognize deterioration of symptoms. Generally, it will take someone 5 days of deteriorating symptoms before they get help from their GP or implement their asthma action plan. 5 days. And again, I'm one of those sad people. I worked it out once and I was like, it was day 5. I went to the doctor and get antibiotics. So we need to get patients to consult their plan sooner and to recognize deterioration and take action. It can either be based on symptoms, if they've got increased symptoms, or whether their peak flow measurement might have gone down. It's up to them. It could be a mixture of both, but this is where the peak flow meter is useful. You can say, look, you normally blow 350 or 400. If you blow below 300, go and see a doctor. So it's really down to the patient if they need to have an actual objective reading or they can monitor themselves symptom-wise. So they're the principles of the asthma action plan, quite straightforward. Have a look in the handbook. The basics of an asthma plan, as I said, normally include long-term management, short-term and emergency, and these are all color-coded. They're quite easy to follow, really. And you can download these online. They're great. And also you get more descriptive ones. This is a specific Symbicort one, obviously produced by the company that produced the Symbicort, who had a great idea with PRN Symbicort. And of course, this reflects what happens if someone's using PRN Symbicort as a reliever, because they just increase their PRN Symbicort. It's quite straightforward. So that's an asthma plan specifically for them. First aid for asthma, you probably know this, 4 puffs of Ventolin 4 times with a spacer, and then wait 4 minutes and keep repeating. I mean, when I last gave this presentation, someone interrupted and said, no, just keep giving it, keep giving it, keep giving it. You can't do too much harm if you do that, to be honest, but the general advice is 4 by 4 by 4. 4 puffs, shake in between, use the spacer, do it 4 times, so 16 puffs in total, wait 4 minutes and reassess. Just remember, people still die of asthma. We're still getting 400 plus patients dying every year. We shouldn't ignore this. And often it's the women that are dying. I think 65% of asthma deaths are women. I think because we plow on regardless and we think we're invincible. We're not. People still die. So a patient presents to you having an asthma attack in your practice, make a rapid clinical assessment. Can they talk? If you can, take their oximeter readings, but initial treatment's always the same. Do that 4 by 4 by 4, it's essential. There's a slide here if you wanted to. I mean, you wouldn't really have time to look at this if someone's having a severe asthma attack, but this really determines whether it's a mild or moderate flare. So of course, if SATs are at a certain level, it will indicate if it's mild, moderate or severe. If it's severe, you can tell quite quickly. Obviously, call an ambulance. They're using their accessory muscles, of course. You've got tracheal tug and subcostal recession. You've got abnormal breathing. You can see it quite clearly. The patient will have that tripod position, you know. Yeah, they're in trouble. Just keep giving that Ventolin. The patient's going to get exhausted quite quickly. And you may not even stop to do SATs. You can tell by looking at them. If in doubt, call an ambulance, of course. If it's a mild or moderate flare and the patient can talk in sentences, oxygen SATs are okay, then obviously Ventolin is fine. But just remember to shake that Ventolin in between. And don't worry about overdosing them. The side effects are really tachycardia, a few tremors. They'll go away after about 30 minutes or so. They don't last. If you've got it to hand, administer oxygen therapy as well. It depends on what's available at the time. If a patient tells you it's an emergency, it probably is. Listen to what they're telling you. Severe respiratory distress, they will have impaired speech. They'll barely be able to speak. Single words, no sentences. Pursed lips, because they're struggling to get the air out. You'll definitely see this pursed lips. And you'll see a patient start to use their diaphragm and intercostal muscles because they'll be trying to compensate. A Ventolin may not be having any effect on them. So definitely implement that emergency care plan. So this is what the patient will look like in the handbook relating to acute and emergency asthma. Really, we advise people to print these off and keep them available in your surgery. Laminate them so people are familiar with them and stick them on the wall. If they are laminated, at least you keep your infection control people happy, but have a glance through it and obviously use what you've got available to you at the time.
Question for you quickly.
Sure.
How much oxygen flow, 2 to 4 litres per minute for etc. could be given in severe asthma?
Oh, sorry, is that what they're telling me? 2 to 4 litres?
How much oxygen could be given in severe asthma?
I actually don't know. I think you just whack it up, don't you, as high as you can, like you would a nebulizer, but maybe someone else out there knows that answer. I would be whacking it right up because I know you can nebulize with oxygen rather than just air. Maybe someone else can answer that question.
I'll let you know if anything comes in.
Yeah, I'm up to Google that one really quickly, but certainly I wouldn't have it on 2 litres. I'd be whacking it up to 5 or 10, I think, if you had it to hand. I don't think they cover that one here, but I'll make a note of it because I'll follow up on that one, Stephanie, to find out. But I think it's as high as you can go pretty much. I think 15 litres is the highest one you normally get.
Mm-hmm.
So the other thing I've got written here, in an emergency, if you have got prednisolone, give them that. That can work quite quickly. That can work in about 30 to 60 minutes. If you've got Atrovent there, ipratropium, stick that in there as well. There's always a place for nebulizers. If someone's in an emergency situation, they've got very little inspiratory effort. Remember that. So if you've got a nebulizer to hand, then use that. People always question whether you should use a nebulizer or a spacer. It's down to your patient and their ability. But if they really can't breathe in through a spacer, you've got no choice. And you can nebulize with salbutamol and Atrovent. And again, if you're in a surgery and you've got it available, use one of the muscle relaxants. If you've got a magnesium sulfate, you can give them IV, then do that. But there's loads more guidance in the Asthma Handbook. So yeah, no, it definitely doesn't say on that slide, does it? No, how much? I'll have a look at the oxygen and get back to you. And once someone's had an asthma attack, you need to find out why. So do that post-match analysis, post-exacerbation analysis. It's a bit like a match analysis, isn't it? What went wrong on the day? Did the patient take their eye off the ball? Did they run out of medication? Were they exposed to a trigger? Find out what caused that flare-up. We need to avoid it in the future. And again, address their understanding of what happened. You'll find so many times patients are not taking their medication because they're too yeah, they're too expensive, and get the patient back into clinic to really review and re-educate them to make sure it's not repeated. Also, do telehealth. They're still doing telehealth, even though hopefully the days of COVID are behind us, but it's a good way to keep in touch with patients. Just touch base with them, pick up the phone, run through those asthma control questions and find out how they're going. That web link, I believe, is just a web link to a fact sheet of how you can bill for telehealth. I think that's still there post-COVID. So I think this might be the last slide, actually. With regard to COVID, what do we advise patients? This slide has generated a lot of discussion. A lot of people have said to me they think asthmatics are protected because they're taking a steroid inhaler. I think they're still doing tests on that, but you can still do lung function testing on patients. We're just doing everything a bit more cautiously than we were previously. Obviously, we're saying to everybody, make sure you've got an asthma action management plan, an action plan, of course, an emergency plan. Make sure you've got sufficient doses left in your preventer and you're filling your scripts regularly, because of course you can't get more than 1 month's supply at the moment. If you don't need to use a nebulizer, avoid it, because it does generate a lot of aerosols, and these aerosols can spread the infection quite a long way. And I do believe the outbreak in Melbourne was caused because of someone using a nebulizer. But also reassure patients that people with asthma are not at greater risk or susceptibility of getting COVID. They might think they are, but no, potentially they may have that added benefit of having an ICS on board. Yes, I'm right. That was the last slide. So I never leave without saying I've got 3 take-home messages. The first one is, of course, patients must take their preventer. Adherence and compliance is everything. If they cannot be compliant, switch them. Stick them onto budesonide formoterol. We have to get inhaled corticosteroid into them at all costs. If a patient is using Ventolin more than twice a week, not twice a day, their asthma is not controlled. I bet you all know somebody who's walking around with one of these in their pockets. That's it. I'm all done. And I think we've come in with about 8 minutes left to spare for questions, Stephanie.
That's excellent. I've done a little bit of Googling.
Oh,
it says in adults with severe bronchial asthma complicated with respiratory failure, the maximum inspiratory flow rate can be 30 to 60 litres per minute according to the asthma grading standard. You can provide low flow gas at a rate of 8 to 80 litres a minute, meeting the respiratory requirements of patients with asthma.
Perfect.
So that's that. Is there any other questions? Would anyone like to lift a hand or type in another question into the question box? So whilst we wait to see if any more questions come up, just a couple of reminders. Don't forget your Polar clinical audit tool. So that can delve deep, and you can look for patients with a range of medications in asthma or lack of medications that have been prescribed for asthma, or it can be as simple as just looking for patients who have asthma or patients who've got asthma and no GPMP or TCA, for instance. So you can go as light or as heavy as you need to. If you need training in the use of Polar, contact our digital health team at digitalhealth@emphn.org.au. They provide training. So there's a good tool there to help you with your planning of what you're going to do with your asthma management. Another resource to not forget is, of course, Health Pathways Melbourne. So it's got clinical information on all things asthma, with hundreds of other clinical conditions as well. So Health Pathways Melbourne is another definite area to not forget. We've got a question. Is it possible to get a copy of the slides? The slides will be attached to your certificate when that comes through, and there will also be a link to this webinar in that email. So yes, that's easy answer. Yes. The other thing, whilst we're waiting, there's no hands up at this point in time. The other peak body that I'd like to draw your attention to is Asthma Australia. So they also have excellent, well, they've got a section, Asthma Connect, which is a section for health professionals, and a lot of useful information there on their website. They've also got Asthma Assist, and this is a free support and education service for patients that you might have who are having difficulty with your coaching and the amount of coaching that you can do, difficulty managing their asthma. So they can provide an asthma educator that will manage that patient one-on-one. Now, of course, you need to get consent from the patient to refer them. Patients can also self-refer to that service. So that's something to be mindful of. Okay, there's no other questions. So my other reminder is Asthma Cycle of Care. There was, of course, the item numbers for Asthma Cycle of Care, which from November 20, from August 2020, when PIPQI came in, the SIP payments associated with the Asthma Cycle of Care dropped off because your PIPQI is meant to compensate you in lieu of the Asthma Cycle of Care payment. However, you still could bill that those item numbers, but from the 1st of November 2022, they will no longer be accepted by Medicare, and remuneration for asthma care will come under the usual time-based item numbers for the service provided. So how are we going? We've got 4 minutes. I think we might finish early. I'd like to thank Kerry for sharing your amazing knowledge and experience in tonight's really informative webinar. An acutely ill patient presenting with asthma can be an incredibly scary scenario in general practice, and your presentation has certainly helped update and refresh our knowledge in the management of asthma in general practice. So that's been excellent. Thank you so much.
Oh, you're welcome.
Yeah, we'd also like to thank all of you for attending tonight and joining us in this and submitting your questions in this presentation to make it more interesting. That's been excellent. We'd really appreciate it. Once you hang up here, you will get the automatic pop-up that leads you. Well, you can click this QR code if you really want to use your phone here and now, or you can just answer the automatic pop-up that will come up when you log off. You don't need to do both. One is good enough. Thank you very much. Your feedback will be shared with the National Asthma Council. And as we mentioned, this recording will be, the link for it will also be shared with you when you get your certificate in a few days' time. We look forward to seeing you again at other events in the future, and thank you very much and have a good night. I'll just check. There is definitely no other questions, and that's it for this evening. Thank you.